Good afternoon, everybody. We'll start the webinar now. I'm Wendy Byrne, I'm the President of the College. Thank you for joining us. We've got over 1,000 people signed up this afternoon, so it's great that you're all here. We've got 3 different speakers, and at the end of that we'll have some time for questions. There's a question and answer panel on the side, so if you can put your questions in there. If it's for one of the speakers, if you could put which speaker the question is for. And then if you've got more general questions, we'll try and answer them, or you can direct them to our policy team. There's an ask a question function on our website. This will show up in the question box. Please do tweet using the hashtag RCPsych live. So our first speaker is Kim Catcheside. She is the college's Director of Strategic Communications. She joined the college in 2016, following a very successful career as a broadcast journalist for the BBC. She's going to take you through the resources on COVID that we have on the college website. I hope some of you will have looked at these already. Before she starts, I'd like to say a really special thank you to our members and the college staff who literally worked around the clock to develop these. Over to you, Kim.
Good afternoon and welcome. It's really interesting to be broadcasting in this way. Around 1,000 people have joined us, which is really exciting, and it's good to see how well this is working. Just on the second webcast that we've been having. So I wanted to give you some of the background to why we created these resources. It became very clear at the start of the pandemic that there was a gap in guidance for those working in mental health settings in responding to COVID-19. And Wendy was literally getting hundreds of questions via Twitter and other outlets. And so we decided to work very quickly to create an advisory group of members and develop detailed guidance across whole areas, liaising with NHS England and the Royal College of Nursing. I think it's worth noting that the guidance can't cover every issue or provide advice on how to manage individual clinical decisions. These need to be in line with local trust policies, but this does provide some overarching guidance, and I hope that you'll find it useful. I think it's important also to say that because we are in a live and swiftly developing situation, my team are updating the guidance all the time and adding to it. We do have a facility, as Wendy has said, to submit a question, which is very helpful in letting us know what the key issues are. And some of them are complex and challenging to answer, so you'll have to bear with us. I have the team working on answering these questions, and we're posting the answers to the questions on the website as we come up. So if I could just go to the website and talk you through how you would get to it to use it. So this is the front page we're on at the moment, and you'll see that there are scrolling banners across the front page. So we've only got 3 things on the scrolling banners at the moment. They're about our webinars, I'm just about to be proved wrong and say that there are 4. But anyway, we go here to guidance for clinicians on COVID-19. So you just quickly click on that and this page comes up, and you'll see that right at the top there are the recent updates. So if you've already looked at this content, and I think that our analysis shows that about 18,000 users have used this content. Within about 3 days we'd had well over 7,000 individual users who had used this content. So many of you may already be familiar with it. If you are, please do keep coming back, because we are continually updating, and this, as you can see, is where we can show you what the updates are. So I'm going to take you through a couple of scenarios. The first is, if you're looking for specific guidance, let's go to community and inpatient settings. So you can see here that there are lots of tabs which take you through the, are designed to answer particular questions that you might have. So let's go to secondary and specialist mental health settings. As you can see, lots and lots of information here. Inpatient services, and our full guidance then you can find on inpatient settings there, which I'm hoping you will all find very useful. And of course, we are also linking to relevant resources whenever we can. So let's go back. My back button mysteriously doesn't seem to be working. So let's go back to the home page and follow another scenario. Wait for the scroller to come up again. Obviously, we've had a huge amount of inquiries around PPE, which is obviously of great concern to all of you, in fact. So where do I find the PPE? This is where the head of my website is going to be cursing me. Seeking advice on clarity on personal protective, probably here actually, recent updates to this content. Ah, yeah, here we are. There you see. It does work if you don't know your way through it. So here we have the guidance on personal protective equipment. And I also wanted to draw your attention to the materials that we've done on the workforce. So particular advice and very, very comprehensive advice on issues of well-being for the workforce, advice for individuals, highlighting the psychiatric support service which the college runs, but also advice for people looking after teams. So where is that workforce international? Ah, here we are. There we are. So this is pretty comprehensive, and it contains an awful lot of our expert advice, as well as links to lots and lots of other things. I'm going to unshare my screen now briefly, so you can see me again, I hope. I just wanted to add that we don't have time to mention all the guidance, so please do take some time to look through it. Some areas are increasingly more important, so we expect new emergency provisions for mental health legislation to be enacted in the coming weeks, and we'll be regularly updating our advice on that. Our guidance has been devolved across all the UK colleges, with each devolved nation having dedicated pages, and indeed in Wales translations. And the faculties have also been collating and developing faculty-specific content, which we're assuring is aligned to the guidance. I just wanted to echo again my thanks to everybody who's taken part in this. It's been an incredible group effort, and I think a real tribute to the way that the college works and the commitment that we have from our many volunteer members. So thank you very much. Back to Wendy.
So thank you, Kim, and thank you for taking us through that so quickly and efficiently. There's a huge amount on there, and I really hope that you'll all spend some time looking at it. So our next speaker is Dr. Golnar Aref. Gulnar is an NAHR academic clinical fellow in psychiatry. She can currently be found working on a COVID-19 ward in Camden and Islington NHS Foundation Trust. She's a digital and wellness enthusiast. So over to you, Gulnar.
Hello, everybody. Hello. I'm delighted to be speaking today about cyber psychiatry versus COVID-19. I'm really hoping by the end of the presentation that you'll be as enthusiastic about telepsychiatry as I am. Next slide, please. So before the lockdown, this is my children. They're a 4- and 6-year-old, and screen time was a rare and precious thing for them. It was really limited, and occasionally we just used it as a sort of digital babysitter for entertainment purposes. And then lockdown hits. Next slide, please. And within a week, we were doing everything online. So that's them doing Joe Wicks. We've also been doing yoga. In the left-hand corner, my 6-year-old's having violin lessons. And then it got more and more innovative. We started doing science experiments with the class online and class assemblies. And it got, 5 days in, it was ballet time. My daughter just ran to the computer, and was ready to go and asked me, "Is it going to be on Zoom, Mum?" And I just thought, wow, that's really, it's a technological explosion really for us. And so when the college asked me to do this talk, I thought, how has this accelerated boom happened in psychiatry nationally? How are people working remotely? So I started, like all good researchers, I did a mixed methods project very quickly. Next slide, please. And I started with some quantitative work on social media. So this is a Facebook and Twitter poll. And I asked, the first thing was really to ask, how are you working remotely with teams and colleagues? And I was actually quite surprised to see most people are actually already using Microsoft Teams, and telephone and mobile sort of phoning in has actually become second to that. And then the next question was really, how are you working remotely with patients or service users? Next slide, please. And then this is what I'm more familiar with. Actually, most people, so this was about 100 people answered, over 70 of them are still using telephone and mobile, and less are using video conferencing, so Attend Anywhere, which is the NHSE endorsed and funded one. So I was actually, this is more in line with what I've been used to, is that, when a patient doesn't attend, we actually do phone them and don't use video conferencing. Next slide, please. So I wanted to explore this further, and on the previous slide it shows that there were 29 comments, just from me doing this poll. People were saying, I'm worried about data security. My trust has said that we can use on our laptops specific social media, so like using FaceTime to call patients on a trust laptop or iPad, and I'm worried about security. Someone else has said about Zoom, is it really protected? I heard that all the information gets sent back to the USA. And so I thought I'd explore this a little bit further and see what actually Camden and Islington are doing. And this is Lorraine Hanna, who's a consultant liaison psychiatrist, and she's also the Chief Clinical Information Officer. So it's a CCIO. And so if you're wondering, what is my trust doing about IT, this is the person to talk to, because they're the clinician, but they're also the kind of working with the IT systems and the IT team in your local trust. And what she did within a matter of weeks was roll out. On the left, you can see Microsoft Teams, which is how we're all communicating with each other. And on the right is Attend Anywhere. And she did it with the IT team in such a rapid way. And I sort of wanted to explore that further. Next slide, please. And you can see that these were the implementation facilitators for her. First of all, she's very proactive, as well as we also have a chief information officer, and he is also very proactive, and he's on the board. And so he was really good at making sure it was on the front line of what we were doing. Of course, the support from NHSE and the funding, so that Attend Anywhere was, we were funded to use it. And there's things that we did in particular, which I think was a really great initiative, was that we had a local level project manager. So for each thing, for Attend Anywhere and Microsoft Teams, for the installation, they weren't actually IT based people. These were project managers who worked at Camden and Islington, and they were brought on specifically to ensure the rollout. They also emailed out asking for implementation champions, and it was really nice. So we got an email saying, do you want to champion this platform? And because I'm really enthusiastic, and even though I'm working on inpatients, I said, well, I'll become the implementation champion for Attend Anywhere. So if anyone's got any problems, they can email me and I'm happy to speak them through it. And because I'm enthusiastic, if there are any roadblocks, I just say, well, okay, this is what we could do. They also set up a national WhatsApp group for all the people who are in that kind of clinical information officer position, and so they could share what they were all doing, so that across all the different trusts, what has been successful. And then the thing that actually the project manager told me last night, and Lorraine has echoed this, is that they're great platforms. So in the past, when we used video conferencing, they weren't very easy to use. But yesterday I set up Attend Anywhere as a clinician, and it took me 50 seconds. And then when I was answering the call as a kind of mock service user, it took me 40 seconds. So they're very intuitive and easy to use. Next slide. As with all technology, there's going to be barriers, and I think one of the major barriers was we weren't prepared for this. Some people had laptops and iPads, but actually, in particular, the laptops were quite out of date. The microphone wasn't good. The audio equipment just wasn't really there. The video equipment was substandard in some cases. And then so when we wanted to get 500 new sort of iPads and laptops in, they normally come from China. So there was this delay in getting all the equipment. The IT staff themselves, of course, were ill because, they've been exposed to COVID-19 just like all of us. So that was another sort of barrier. And then what's interesting, the project manager said that by the time we were rolling these things out, a lot of consultants and SBRs had been using their own initiative and set up various other ways of contacting patients. And they were sort of like, oh, well, this is what I've decided to start using. And then the technology itself, so for example, Microsoft Teams requires Windows 10, and we only had Windows 7. And so that took a while to get everything up to date. Next slide, please. The thing I loved about doing this kind of very small piece of research was that I'm working on an inpatient ward. So I thought, oh, well, this doesn't really apply to me. But actually, what I have learned by doing this research is that in the comments, people started telling me that they were working on COVID-19 wards, and what they were doing. So this is my SHO on the left and ward manager in the middle. They were being very, very careful. And so actually, they were just having one person, one SHO, who was going around at in the bottom, with full PPE. And they were using video conferencing to bring in the SPRs and the consultants. So they were limiting their exposure. And I think it's a really sensible idea. They also gave me this incredible idea of using video conferencing to have multiple conversations. So I used Attend Anywhere today to wish someone happy birthday. So we were singing happy birthday for a patient with COVID-19, but we but we used Attend Anywhere to have lots of their family members come and sing with us. And it was just little moments like that that really make the difference. Next slide, please. I then did some more sort of qualitative work, and this was an unofficial focus group. On the left is Krish, and she's a consultant old age psychiatrist. And on the right is Amber, she's a consultant child and adolescent psychiatrist. And they're both working remotely. And it's really interesting to hear about their experiences of it and what they've learned. And in terms of etiquette, they said preparation's key. So you think, oh, I've got a consultation at 3, but make sure that 15 minutes before that everything's set up. And if you look at their pictures on the left, Krish is wearing a really nice purple top, and on the right, Amber's set up a really beautiful painting in the background. And actually, if you think about on telly, it's not magnolia walls that's being projected, and that's particularly why Wendy looks so lovely. She's got a bright yellow background, and actually there is something more engaging and attractive to the eye when you spend just a little bit of time thinking about what you're wearing and what your background looks like. For their own sake, they've put themselves, both of them, next to a window, so they've got natural light. They've put plants around them, and at the start of every consultation they ask consent and who's around, and they show their badge. And I thought that was really just simple. It feels professional. It's a really good idea. In terms of team meetings, this is so important, and we did a class assembly with 1 million kids who weren't muted, and it was so loud. So just when you're having a team meeting, mute yourself when you're not speaking. And then in terms of your own well-being, move, because otherwise she was saying, you know, Amber was saying you could spend 8 hours a day sitting and just, you know, talking to people and talking to families, and actually just moving is really, really important. And have, I would say, a digital holiday at times, you know, have a weekend off from all digital technology, like a detox, just to restore yourself, because on, you know, come Monday it's going to be back on again. So next slide, please. So I was complaining to my husband about, you know, how I'm sort of a 1950s housewife. I'm doing all the cooking and cleaning, and I work clinically, and we were laughing about it. And I was thinking how, and then I said, you know, how impressed I am by this sort of very small poll and sort of focus groups and interviews. I found out how people are nationally are responding in a time of crisis really quickly with amazing use of digital technology. And so then I suddenly thought, you know, how can I work things differently? So I don't know if you know this lady. She's a celebrity cleaning influencer. She has an incredible following on Instagram. So I started playing a new game with my children, which is Mrs. Hinch Says. And so we watch what she does on Instagram. And then if you show the next slide, we copy what she's doing. So it's become this really fun game of Simon Says for the tech, for cleaning. They're hoovering, mopping. I mean, they've just got so involved by watching her on Instagram. So I think I'd say that, you know, necessity equals opportunity. It's really exciting, and this game is something I'm definitely going to take forward. And I think all the technology we're using now, we are going to carry on using this. This has completely changed the way we work, and I think it's really, really exciting, actually. So that's it from me. Thank you for listening.
Thank you, Golnar. That was really brilliant. That was really practical and interesting, and that's given me some ideas to go in and think about. Our last speaker this afternoon is Dr. Lesa Wright. He's going to be joining us by phone rather than by video, so you won't be able to see him. Hopefully you'll be able to hear him okay. He's a consultant psychiatrist. He's the Artificial Intelligence and Machine Learning Lead for the Informatics Committee at the college. And he's also the Chief Technology Officer at Psychiatry UK, which provides online mental health consultations across the UK. Over to you, Lesa.
Thanks very much, Wendy. Good afternoon, everybody. My talk this afternoon is about speech-to-text transcription. And the reason I'd like to share my experience about this with you is that given the way we've had to change the way we're working, I thought it might be useful to talk about how I've been working for a while now. Since many of us are separated from our admin teams, it's helpful to find ways to be relatively self-sufficient with respect to our admin. Right, so what I won't be able to do, however, is talk about all the offerings that are out there for speech-to-text transcription for healthcare. So getting started, about 15 months ago, I needed to reduce the turnaround time for clinic letters. Up until that point, I would dictate a letter on an analog dictaphone, and this would then be put into a typing queue. And it could take up to 2 months for a letter to be typed, and this was simply because of the pressure my secretary was under to perform various other service-related admin duties. As a result, I would then suddenly receive a flood of letters to check and had very little time in which to review them. So I thought I would give speech-to-text a go and had a look online to see what was available. But actually, I figured my first option really is to go with Google Transcribe in my phone. It made a lot of sense. It was free, and I could get started straight away. The first thing that should jump to anyone's mind in this endeavor is the question of privacy of patient data. And I got around this by using pseudonyms for all my patients. So I would use and still do use a handful of pseudonyms for all my clinics. And as a result, for example, I have loads and loads of appointments in which Bruce Wayne has been treated for bipolar disorder. In others, he's been treated for schizophrenia. And in others, he's been treated for personality disorder. I also made a point not to mention the names of my colleagues, patients, family members, or others involved in the individual's care. Lastly, I also made sure not to make any reference to geographical locations and used pseudonyms for common locales. This is important because in terms of reconstituting a person's identity, the most useful information a person needs is basically geographical and at age. So I wouldn't mention age in a letter, but obviously if there's a name in there and a geographical location, it's very easy to work out who somebody is. Right, so at the end of that clinic, I would then send all these dictations to my work email and copy them into Word, then use the find and replace feature to replace the pseudonyms with correct names. I'd also use the find and replace feature to correct errors. Now, this process in itself is quite tedious, and it helped writing a Word macro. Now, a macro is a program that you can write inside of Word and other Office products that you can use to add new features. They're really easy to write. You can find references online, and I wrote a macro after looking at a tutorial for half an hour, and that macro has saved more time than you can imagine. Now, this macro corrected common transcription errors. For example, Google Speech-to-Text often made mistakes with the phrase new paragraph. It would transcribe it instead of moving the cursor to a new paragraph. It did the same with phrases like open quote and close quote, rather than inserting quotation marks. So the macro worked to fix these problems, and that saved a lot of time, but it was only suitable for errors like this. There were other errors, such as when Google would replace the word he with it and her with the. And you couldn't simply run a simple replacement program over the text, because then there would be lots of false positives. On the whole, I think it worked quite well. And instead of having to wait weeks for letters to be ready, the main body of a letter was generally ready the same day or within a few days, depending on other pressures. After doing this for about 8 months, I switched to something called Nuance Dragon Dictation Anywhere. This is a relatively low monthly subscription charge application that you can put on your phone. And overall, I found this to be a better experience than using Google Dictate. Since starting to use it, I have not used the replacement program, as the kinds of errors I mentioned earlier do not occur in it. It still struggles sometimes with he and it, but generally performs better than Google. I found that the most irritating issues around new paragraphs and quotation marks were gone. Additionally, being able to add vocabulary has helped reduce the error rate. You can also use a single phrase to add whole blocks of predefined text. Now, the Dragon application transcribed most medication names reasonably well, particularly if it is a medication that's likely to appear fairly commonly in popular media. And that simply has to do with the way these transcription applications are trained. It did struggle with proprietary or branded names such as Concert Excel or Equisense. And for that, I had to add vocabulary to the application. Also certain signs, such as euthymic, for example, I had to add that to the vocabulary as well. Now, within Microsoft Word itself, which I was using to do my final cleanup, there's also a dictate option. And its performance is about the same as Google Dictate. I found it useful for making quick corrections or additions to letters if I had forgotten to do something, because I can still speak faster than I can type. And it performs poorly with technical terms. Another downside is that it doesn't have a way for you to modify the vocabulary. On the whole, I've found speech-to-text dictation to be a good productivity boost, but you do have to do proofreading, and it's helpful to use an autocorrection word macro if you can. The nuances of pronunciation errors are likely to be different from person to person, so it's helpful to experiment before you decide whether or not it's for you. Some additional practical considerations is that it's important to speak clearly at a moderately steady pace, and it helps to emphasize words. With drag and dictate, it also works at arm's length, which is handy as I can put my phone on the desk and read my notes. The less ambient noise there is, the better the performance. Something I found useful is not to check the dictation as I go along. It is actually better to complete the dictation without looking at it. Otherwise, it just takes longer than it should, really. Another point is if you're using Microsoft Word dictation, it's good to have a decent quality microphone. I used the microphone on my web camera for a while, and that gave a quite disappointing result. And once I switched to a dedicated, better quality microphone, the performance improved considerably. And also in terms of measurable productivity, I find that it takes me between 3.5 to 5 minutes to dictate a single page of my handwritten notes through automatic transcription. So in practice, my Goldilocks zone is really 1 to 2 pages of notes, as I might find in an outpatient clinic. Anything longer than that, and the amount of time spent checking and editing really results in lost productivity. So I prefer to send anything like that to a human transcriber. And it might be worth knowing that I've read most of this from notes that I dictated with drag and dictate. And that's all I have for you at this point. And back to you, Wendy.
Okay, thank you very much. So we've had 3 really different speakers, all really interesting, very different topics, and we've now got some time for questions. I've seen some of them go past. I've answered a couple of them. Somebody's asked about PPE and restraint. We are aware that that's a problem. Anything that we publish about PPE has to be agreed with NHS England and with PHE, so we're working on that now. We're trying to get something out quickly. Somebody's also asked about Section 12 courses online, and we are looking at setting those up as a college so that you'll be able to do them online. Right, I'm going to see if I can find a question for our speakers. So somebody has asked, the evidence of telephone calls being good enough for assessment and for treatment. I guess that would be telephone calls and video consultations. Lesa, do you want to say anything about that?
Sorry, is that for me?
Yes, is that all right?
Yes, that's fine. Yeah. So I think there's a fair amount of guidance around the world around remote consultations, video consultations in particular, and telephone consultations for mental health as a backup for video consultations. So if you've got access to a video consultation platform, that is preferable to telephone. If you don't have that and you have to do a remote consultation, or indeed if your video platform lets you down, then a telephone consultation is suitable.
Okay, thank you. So there's another question here. How do we organise a CPA meeting involving patients and a care coordinator? Gulnar, could you pick that up?
Yes, I'm happy. So what we've been doing is we've been using Attend Anywhere, but you can use Microsoft Teams as well, because you can use both with service users, the care coordinator and the family. So they have multi, so you can have various people in a room. I've successfully used Attend Anywhere, and I don't. It's because it's quite easy for me to just send the link out to the relatives, and they can both. They both go into a waiting room. So the way Attend Anywhere, the reason I like it is that. So what happens is it has a virtual waiting room, so I can see that, for example, the relative is there. And the care coordinator's just arrived, and so you can kind of bring people in, and it's a bit like, you know, what you would do in real life. You know, you might bring the care coordinator in first with the family member and have a chat, then bring in the service user, and you can kind of play around with it. I found it actually quite easy to do, and I definitely think it's actually increased, because in the past care coordinators couldn't always come to ward rounds, and actually having this is even better, really.
Thank you. There's another question. I think this will probably be for Lesa again. Can voice to text software be installed on all trust devices as standard? It sounds like a very straightforward way to enhance productivity. I'm disabled and have been trying to get it on my trust laptop since August with no luck. Thank you. Presumably, Lesa, presumably it could be installed, but people just don't want to. Do you have a view on that?
Yeah, it's part of the issue is simply down to cost, and I think, given the current circumstances and the way we're all being forced to work differently, I think that's something that will become a priority in future. I mean, my talk really has been around working around a system that doesn't allow you to innovate quickly. So I found using this approach where you anonymize your patient's information as you dictate protects their identity, it protects their data. It's a bit more work for you, yes, but in my experience, I saw some significant productivity gains as opposed to at the time typing it all myself, because I'm not a very fast typist, and engaging in a struggle with the trust to try and bring this technology in. Yeah.
Thank you. And somebody's asked about Dragon. I don't know if you also know the answer to this question. Okay. Is there a medicine specialist Dragon, or is it just the normal Dragon that people should? Certainly, I use the normal Dragon. That seems to work okay.
Yes. So when I was looking into this initially, there's basically three primary versions. There's the Dragon Anywhere, which you can download on your phone. There's one that you can install on your computer, and there's what they call a, in quote, pro version of that as well. And they have an enterprise version, which has a medical module. So what surprised me is that they don't provide access to the medical module for clinicians, individual professional clinicians wanting to use it. But I found that actually for day-to-day work, the Dragon Dictate works really quite well. Once you get into a routine, it becomes easy to see what you need to add to the vocabulary. And in all honesty, I haven't added much. I would say I've probably added less than 10 words to the vocabulary. And I've dictated hundreds of letters from it.
Thank you. There's another question here. Gulnar, I don't know if you could answer this. Do you have any information on virtual cognitive assessment tools like Mocha or ACE3 that we use with our elderly patients? I don't know whether you would know anything about that.
No, I don't. It's a really good idea, actually. I've never really heard about it. I'm imagining that old age psychiatrists are doing the assessments, but with like a carer or a relative there helping. I mean, this is the way I would do it: is send a copy of it by email to if they have a carer or a relative, or they're in a care home, and then you would. They would have a copy and you would have a copy and you'd be going through it that way. But I mean, I just remember from old age psychiatry, they're quite in depth, some of those things. So it's a good question, but I'm not sure about whether there is anything virtually to do that. Thank you.
Most of my patients couldn't really do video conferencing, as then don't have the equipment. So I've just been doing a lot of consultations by ordinary phone. Somebody's asked if you can use the webinars towards CPD. Yes, as long as your peer group approves, that's fine. If there's any other questions, anybody have any other questions for our speakers? I think we've covered most of them. There are some comments, but I think in terms of the actual questions, we've covered most of them. There's some individual questions. If you want to put them through the portal and ask for them to be passed on to me, then I will reply. Okay, so I think that's most of the questions. So we'll finish there. Thanks very much to all our speakers, and thanks for the audience, and see you again. Goodbye.
Thank you. Bye.